let's go over some chiropractic terminology. People hear these terms but they don't even know what they are. What are corns? But podiatric terminology is very common. In course, basically are accumulations of skin on the toes. Generally it's associated with the toe that instead of laying flat is bent. And so what happens is shoot pressure will accumulate tissue. That tissue is called a corn, that in turn actually makes pressure on the nerve underneath and is uncomfortable. So most people think the corn is a growth. You kill the growth and it goes away, but it's really the deformity of the toe. Generally, the bending of the first knuckle on a toe. That is the underlying cause of the problem. What about buying a bunion is also a deformity of the foot. That is, it happens to be congenital and origin. So bunion is where the first metatarsal bone in the it drifts towards the other foot. Now, most people look at a bunion. They see a bump on the side of the foot, and they think I just grew a bump on my foot. But in reality, it's a shifting of bone. That thing is associated with the big toe. Moving towards the small toe side of the foot, this then accentuates the hammer toes that are oftentimes associated with the corners. We just spoke up almost slash. Both spurs are accumulation of bone, and these typically will occur where there's traction for. It's in the Achilles tendon. We frequently see athletes who have Achilles tendon traction type spurs. These project off of the back of the heel bone. And what happens is a runner, for instance, or someone who does a lot of basketball or other court activities. They develop that calf muscle. It gets real strong, but it gets short, and that makes the Achilles tendon pull a little harder on the heel bone. That creates traction. And that traction creates growth of bone. Similar spur is one of the bottom of the heel, which is traction of the like all the plantar fascia as it pulls against the heel bone. And its pathway going up towards the toes. This is oftentimes associated with the flat foot, or also associated with a shortened Achilles tendon. I've been people tell if they have an arch problem. General, you can tell if you have an arch problem by looking at your ancestors, your the heredity nature of the thing. So, for instance, if you have an arch problem, or you think you do, and you just simply have a flat arch. But if you look at your parents, grandparents also, siblings, and nobody has any associated deformities such as bunions, you generally don't have to worry too much about it. But the easy way to do it is have someone else eyeball you from the back as you're standing barefoot, looking away from them. And look at the Achilles tendon's direction downward. If the Achilles tendon direction downward is pretty much perpendicular to the ground, you generally don't have much of an arch problem. If it deviates outward towards the small toe side of the foot, and you generally know that you have each problem. We've often talked about the shoes of people select, especially women's shoes, but you've been your experience about the selection process for shoes. Well, it's real interesting. You ask that, because there's been a phenomenon now, especially in the sports world, where people are going to, in quotes, barefoot running or unconstructed shoe running. And they're thinking, this is getting back to nature and so forth, but I've already accumulated a handful of people with metatarsal fractures. The last week, I had a young lady who had a 2-inch piece of wood stuck in her foot with a very deep infection that we had to take to the operating room. So as far as athletic footgear, what we always talk about is get the proper shoes for the proper sport. So for instance, most of us say the word tennis shoes when we mean any athletic shoe. Tennis shoes are specific for the sport of tennis. They're flat. They don't give a lot of arch support. They're not meant to, and they're not meant for running. So if you're a runner, get a good quality running shoe. If you do court sports, basketball, or what have you, get a court shoe. Women's shoes, women typically are wanting to wear, especially in their younger years. An elevated heel. If you wear of an elevated heel 1.5 to 2 inches, probably no problem. If you have a little bit higher than that, and the sole is raised, so you have sort of a platform effect, not much of a problem either. But if you wear in the 2-inch to 3 to 4-inch range frequently, what happens is, number one, you load so much pressure on the front part of the foot. that if you have one of those deformities we talked about earlier such as bunions, or hamartos, you put more pressure on, you make it grow faster, even though its origin was heredity. Now, other thing that you do, if you're a woman and you're wearing high heels all the time is, you ultimately shorten your Achilles tendon. As your heel goes up, your Achilles tendon relaxes. Nature doesn't like a void like that. It will shorten the tendon that makes it uncomfortable to wear flat shoes in later life. The only expression we talked about it. Jimmy Choo may not be for you. Is that correct? Jimmy Choo may not be for you, or at least maybe only one day a week. Alright, tell us about the things that you can do now as a podiatrist. Since you couldn't do 10-15 years, it's really neat to watch the medicine evolved in. You've seen in all the fields that you interview. But one of the nicest things we have, are these miniature instruments now. So, for instance, for the athletically, endeavor type person. A lot of people develop bone spares. As we talked about around the ankle bone, and it frequently occurs with people who do basketball and other court type activities, and these spurs in days gone by used to be somewhat disabling. There used to be a major project to get them gone. We have to make a big 3 or 4 inch opening, use hammers and chisels and so forth, and take them out and lay somebody up for quite a while. Nowadays, we have these miniature scopes. They're 4 millimeters in size. We make a small opening on one side of the ankle. We put a scope in which is attached to a miniature TV lens. We look at the TV monitor, and on the other side, we put little vacuums and drill suction devices to clean things up. User requires only a stitch on each side, and that takes care of the problem. Another one that I'm really excited about. Also the use of a scope, and it's also a 4 millimeter scope, and that's where people have painful heel spares. So most heel spares we get better with typical type of treatment known as physical therapy. Stretching exercises, orthotics, shoe devices. In those rare cases that people don't get better with it, we can treat this with a scope. I go in with a little 4 millimeter opening, release the ligament known as the plantar fracture, literally a 5-minute operation, and the patient walks away. They have a stitch on each side of the heel, and within about 4 days, they could take a shower again, and they're back to their regular activities into 3 weeks. Another one that we've talked about, maybe a couple times before, is shockwave therapy. Now, we have ultrasound, which is the physical therapy type thing where you put a sound wave on someone, you warm up the body part. But we have ultrasound now, so powerful that it can fracture kidney stones in kidney stone. Removal is called lithotripsy. And to remove the effect of bone spares, it's called shock wave therapy. So essentially a large machine is utilized, and it is applied to the area where the bone spur is, and it literally dissolves the problem. Vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis likely to Candida albicans on wise woman. Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis, several vulvovaginal candidiasis, non-albicans. Candidiasis, women with diabetes, immunocompromised, and conditions, debilitation or immunosuppressive therapy by the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness. A diagnosis of Candida vaginitis is just to clinically. Signs include fissures, vulvar edema, excoriation, xanthic, curty vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a gram stain or red preparation of vaginal discharge demonstrates budding yeasts, pseudo-hyphae, or a culture or other tests yields a positive result for a species use of 10%. Co-preparation in wet preparations improves the visualization of micelle, lium and yeast by disrupting cellular material that might obstruct the visuality of yeast, or a pseudo-hi-fi examination of a wet mount with cup preparation should be performed for all patients with symptoms or signs of vaginal candidiasis for patients with negative wet mounts, but existing symptoms or signs. Vaginal cultures for Candida should be considered. 2 days ago 4:45 p.m. performed, then an empiric treatment can be considered. Identifying Candida by culture in the absence of signs or symptoms is not an indication for treatment. Since approximately 20% of women harbor Candida sp and other yeasts in the vagina, however, postcoital testing for yeast is not approved by the Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated mobile vaginal candidiasis have no identifiable precipitating factors. Short tours top of effectively treat uncomplicated vulvovaginal candidiasis. There, topically applied, azole drugs are highly effective than NICE. Anton treatment of azoles results in relief. Symptoms and negative cultures in 90% of patients who complete therapy over-the-counter intravaginal agents. Clotrimazole 1% cream 5 grams intravaginally daily for 7 to 14 days, or clotrimazole 2% cream 5 grams intravaginally daily for 3 days, or miconazole 2% cream, 5 grams, intravaginally daily for 7 days. Miconazole 4% cream pi, 5 grams intravaginally daily for 3 days, or miconazole 100 mg. Vaginal suppository 1 suppository daily for 7 days, or miconazole 200 gram. Vaginal suppository 1 suppository for 3 days. Warm miconazole 1200 mg. Vaginal suppository 1 suppository for 1 day. T-alconazole 6.5% ointment 5 grams. Intravaginally in a single application. Patient prescription intravaginal agents: buto, carnazole 2% cream 5 grams intravaginally in a single application, or tercarnazole 0.4% cream 5 grams intravaginally daily for 7 days, or tercarnazole 0.8% cream 5 grams intravaginally daily for 3 days. Terconazole, 80 mg, vaginal suppository. 1 suppository daily, for 3 days. Oral agent fluconazole,